Okay, so let's break this case down. So we were talking about managing a myocardial infarction, specifically a patient that has bradycardia, which happens in but roughly 25 to 30% of myocardial infarction patients. So let's look at this case. First off, while you're here, just remember that as a organization, as Master Medics, we help students that are struggling in school understanding physiology, understanding pathophysiology, and getting past their exams. That is what we do. That's what we are experts in. And so if you're struggling in school, if you're trying to get past your exams and you need help with that, we have the stuff that you need in order to make that a reality. So if you love the way that we teach and you want to check us out at courses.mastermedics.com, and you can check out everything that we have to offer. Okay, so here's the case. You're dispatched to a female patient who is complaining of nausea, dizziness, and epigastric pain. You arrive to find the patient sitting upright in bed and vomiting into a bowl. Here's the presentation of your patient sitting upright and, like I said, vomiting into a bowl. And these are the paramedics that are about to set up to do your vital signs, which leads me into that next piece. This is what you find when you do these vital signs. You find a heart rate of 36, a SpO2 of 94%, a BP of 85 on 54, and a resp rate of 24 reps per minute. And so this is what you have here. Now, as far as this rhythm, what is this rhythm that you see here? I'm going to pop it up so you can kind of get an idea of what you feel this rhythm actually is. Okay, so as far as this rhythm goes, if you see the P waves are not discerning with or not correlated with the QRSs. And so what we are seeing here is that there is complete discorrelation between the P waves and the QRSs, and this is a highly indicative of a third-degree block. So that's what we're dealing with right here, is a third-degree block with associated bradycardia due to that. So we have a pretty serious problem that's going on here that's obviously causing some issues. And so my first question to you is this patient compensating right now, or are they decompensating? Are they in a lot of trouble right now? Go ahead, put that in the comments. Right, I would agree with you, is that this patient is not compensating at all. In fact, the compensating factors that we use in order to manage our blood pressure, in order to manage perfusion, are not working because of damage to this heart during this myocardial infarction. So in this particular case, what we're dealing with is a decompensated state of cardiogenic shock. Which leads me to the next question, is what causes bradycardia? Like I said, 25% to 30% of patients that have myocardial infarctions have associated bradycardia. So what causes that bradycardia in a myocardial infarction? Well, what causes that bradycardia is simply damage to the pacing pieces that we use in order to drive the heart rate. And those two pieces that we use are going to be the SA node and the AV node. And so the SA node sits, as we know, up in here, and then the AV node sits down in here. So we have SA and then we have AV node that are going to be driving the rate of the heart, particularly the SA node, and then if the SA node fails, then the AV node. There is a kind of a fault to this issue, though, is that you have both of these pieces that are going to drive the rate of the heart in order to create good contractility and good rhythm. The thing with that is an issue is that these particular nodes are actually fed by this same vessel. So this vessel right here that I'm outlining is your right coronary artery. And the right coronary artery for most patients is feeding, like I said, the SA node and the AV node. It's feeding its blood supply. And so when we have changes in blood supply from that is going to the SA node and AV node, they are going to become dysfunction. They're not going to be able to pump blood. They're not going to be able to send electrical impulses properly in order to create impulses. And so then when you start to see bradycardias with associated myocardial infarctions, this is usually due to a damage to the blood supply to the SA node and the AV node, and it's not allowing them to command the contractions of the heart itself. And so that's where we start to see a lot of this bradycardia. Now, how does this create your cardiac output problems, our blood pressure problems? Well, we know that the heart rate itself is a big part of creating cardiac output. But remember that this patient's cause, the reason their heart rate is in dysfunction, is having issues, is because of a myocardial infarction. And remember, this right coronary artery here not only feeds the SA node and the AV node, it also feeds an inferior portion of the heart, as well as the right ventricle, and also in a lot of patients it is also going to be feeding the posterior portions of the heart. So it's a very large portion of the heart that's actually going to have its contractility severely diminished. And so in these particular patients, not only do they have a heart rate issue that's impacting a decrease in cardiac output, but they also have an impact in their stroke volume and ability to contract the heart itself. That's also going to have a decrease in cardiac output. And so this is why we're starting to see significant blood pressure issues, is because of both of the side of the coin here is creating an impact on cardiac output, resulting in poor perfusion or a decrease in blood pressure. Okay, so let's talk about the treatment. Now, first and foremost, to remember that we've talked a lot about the rate and the bradycardia and why that's occurring. But keep in mind that this patient, the association between myocardial infarction and the bradycardia is really important. This is still a myocardial infarction patient, which means that we need to treat it as such using things like aspirin in order to help with the myocardial infarction. So that's the first and foremost thing, making sure we get oxygen on them, make sure that we use aspirin. Now, the next thing is, should we be giving fluids to this patient? This patient's bradycardic, which is causing a hypotension. Can we use fluids in order to increase that blood pressure and help it? Yes, so from a basic standpoint, we can absolutely use isotonic fluids in order to increase the blood pressure, increase the volume inside the blood, and increase the preload. One caveat to this is that making sure that they do not have any pulmonary issues and pulmonary pressure issues like pulmonary edema, those types of things, and crackles in the lungs. If they do have any pulmonary concerns, then fluids are going to precipitate to that problem. They're going to actually damage them even further. So that's the first thing, is that if you're going to use fluids, one thing that you need to make sure is that there is no pulmonary compromise first, and then we can start to introduce fluids at about 250 ml boluses at a time and doing our reassessments. But absolutely, we can use fluids in these cases in order to improve that blood pressure, get it above 90, so that way we know that we have good, strong perfusion that's moving through that heart, again, if there's no contraindications. Now, let's move into some of the treatment for the bradycardia itself. So first off and foremost, one of the first ones that you're going to see on most bradycardia algorithms is atropine. And the dose now from an ACLS perspective is the 1 milligrams IV push. And so this atropine, what it does is it's going to stimulate the SA node and the AV node. It's going to stimulate them. Now, keep in mind is that atropine is a good medication. We want to make sure that we have good dosing on that medication, because if we go below the 0.5 milligrams, we're going to actually have a reverse effect of this medication, and we can actually have worsening bradycardia. So it's important to remember that we get the dose correct and we're not underdosing, because we can actually have a negative effect of what we want. Now, in this particular case, according to ACLS, is this medication going to be our first line for our particular patient? Go ahead and put that in the comments. Is atropine indicated for this patient in their present situation? Go ahead, put that in the comments. Now, the answer to that question is no. They wouldn't be indicated in this case. Now, could you use it down the road? Should it be your first priority? No, it shouldn't. But down the road, sure. But in this particular case, we have a patient that has a decompensated state of shock, and they are bradycardic due to a myocardial infarction, and they're decompensating. And so atropine is a great medication. However, our priority here is going to actually be using something like pacing in order to improve the contractility, improve the heart rate itself. And that's why our priority is not atropine in this particular patient. Our priority is using pacing in order to improve this patient's situation. So that being said, let's talk about this pacing process. Pacing is basically what we're using those pads in order to drive the heart rate. And this electrical stimulus is going to drive a is going to drive the electrical impulses to increase the heart rate itself. And so it's going to be a kind of a rhythmic amount of impulse. And so how does that work? Well, this is our underlying rhythm here, this heart rate here, and we can see the direct correlation between the heart rate and the SpO2. You'll notice that there is a waveform on your SpO2 for every single ventricular beat here. This is that correlation. So we know that our physical rate, the amount of blood getting to the body itself, is correlated with the underlying rate right now. Okay, so we can use this as we move forward with the pacing process. So first off, once we get an idea that we're going to decide to pace, we are going to set up the pacer. And when we set up the pacer, we're going to set a rate. Now you can set the rate at 60 beats per minute, which is what we're setting here. And when we do this, you'll notice that there's triangles above the underlying rhythm's ventricular beats, and you're also seeing pacer spikes as we increase the milliamps. And as we increase the milliamps, what you want is these pacer spikes to be right in line with the QRSs. So as we increase the voltage, you're going to notice that these pacer spikes are now going to generate a ventricular beat. Watch there. And you can start to see it as we got to 60 milliamps. We were able to generate an electrical beat that generated a physical beat as well, and then we increase it by 10 more milliamps in order to make sure that we sustain that. And once we lock that in and we see that, let's take a look at our SpO2. You'll notice that we have a direct physical waveform with every single ventricular beat. That's good news. It means that we are pushing actual blood with every ventricular beat. Next thing we need to do in this particular case is confirm that we have improvement of blood pressure. So we're going to run a blood pressure to make sure that we're actually creating good perfusion and we've started to restore enough perfusion, which is going to help this patient compensate for the issues they have at hand. So let's see how this blood pressure ends up. It's about done. Come on, it is there. So 100 on 64. So that's good news. So we have an improvement in blood pressure. Now, let's say we didn't. Let's say we ran a blood pressure and we ended up with an NIBP of, say, 88 on 50. Something along those lines where it's quite poor still, even though we have good capture, we have good mechanical capture, and we can see that with good mechanical waveforms with every single ventricular beat, but we have still poor perfusion. We don't have as good a perfusion as we were expecting. Why is that? Why would that occur? Well, that occurs because of the inability for blood to be pumping. And so is there anything that we can do in order to improve the result of pacing? So is there something pharmacological wise that we can use in order to improve the pacing and improve the perfusion? Go ahead, put that in the comments. You're exactly right, is that epinephrine might be a really good choice in this situation. So what's happening here is, what's happening from a physiological standpoint is that even though we're now creating contractility, we're creating an improvement of heart rate, okay, and we've improved the stroke volume, which is contractility is a part of that stroke volume. But remember, stroke volume also is preload. It's afterload. Okay, and it also contractility. Okay, so there's a few things that actually make up stroke volume, which ultimately is going to encompass your cardiac output. So what we've been able to restore with the pacing is that we've restored the heart rate. We've probably restored some contractility as well, using the electricity in order to drive more contractility. But if we have poor preload in this ventricle, it means that it doesn't matter how good our contractility is, it doesn't matter how great our heart rate is, if we have no blood in this ventricle prior to contraction, we're not going to create perfusion. We need flow of blood for that to occur. And so what are some things that can impact preload? Well, things that impact preload are, for one, blood return back to the heart. Okay, low amounts of volume, okay, or blood return back to the heart. So let's start at low amounts of volume. Has this patient lost any blood? Are they septic? There's nothing to indicate that they're septic or that they've lost or they're hypovolemic in any way. So that's probably not the reason why we have poor preload. The other thing is, are they able to return blood back to the heart? Well, they've already had a poor cardiac output for a while, and cardiac output has a pretty big impact on systemic vascular resistance and moving blood. So chances are is that we have poor preload in this heart because blood is not returning back to the heart nearly as well as we would like. So how can we improve that? And you can exactly right in saying that we can use epinephrine in order to improve that. We can use it to cause vasoconstriction that's going to improve blood return back to this heart. We can also use fluids as well, as long as we're reassessing to make sure that we're not causing any pulmonary compromise as well. But those are the two things that can help us improve preload. So let's talk about epinephrine and how we can use that. Well, here's how we typically use epinephrine, how we typically draw it up. And we typically, in a bag, is we're going to draw up epinephrine in 4 milligrams inside a 250 ml bag. 4 milligrams in 250 gives you 4,000 micrograms in this 250 ml bag, which equals 16 micrograms. You're going to have to do this conversion in order to do this properly. So you're going to have to convert your milligrams into your micrograms in order to give you a microgram per mil concentration. So that's the first thing. Now, what's the dose for epinephrine? Now, I went with my range of dose within my protocols. It might be different than yours, but our range for epinephrine in bradycardia, particularly for a flow rate of 0.1 micrograms per kilogram per minute to 1 microgram per kilogram per minute, which is a lot. That's a lot of epinephrine. Okay, so that's our concentration. Now let's talk about kind of what that looks like practically. So 0.1 micrograms per kilogram, let's use that first off. So let's say our patient is 70 kilos, okay? 70 kilogram patient. Now with a 70 kilogram patient, that means that our minimum dose is gonna be 7 micrograms per minute to our maximum dose of 70 micrograms per minute. Okay, 70 micrograms per minute. So that's our max doses and our minimum doses. Now that we have that range, now we can start to set up. Obviously, we're going to start setting up much closer to here and work our way to here as opposed to the other way around. So we're going to go low dose and work our way up. That's kind of the idea that you want to use this in. So let's talk about the math in order to figure this out in case you don't have a pump that's going to do it for you. So let's go back to remembering that we have 16 micrograms per mil. Okay, and we know that our dose, we're going to start here at 7 mics, at our minimum dose. We're going to send that through and do the math for that. So how do you do this? Well, step one, we need to figure out how many mils are in 7 micrograms given our concentration. So that's what we got to figure out. So 7 micrograms, okay, divided by 16 micrograms, because we know that's 16 micrograms per mil, right? So 7 micrograms divided by 16 gives you 0.43, almost 0.44. Okay, that's how many micrograms, that's how many mils has 7 micrograms. Okay, we need this in order to create our flow. So that's how we know that. That's the first step, is figuring that part out. The second part is determining how many mils are needed per hour. Well, we know that we need 7 micrograms of epinephrine every minute. Okay, when 7 micrograms of epinephrine is 0.4375 mils. Okay, that's how many mils we need every single minute, but we need it in hours. And so we're going to take this number here, okay, this number here, down here like so, and we're going to times that by 60 minutes because we know we need this amount of fluid every single minute. So let's find out what it is in 60 minutes. Times 60 gives you a flow rate of 26.25 mils per hour to give you 7 micrograms of epinephrine per minute. Okay, that is the concentration, and that's how we get to that dosing or that run rate. Okay, so let's go and do the other side of this. Let's say that we have to go to the max. Okay, so let's do that. 70 micrograms, well, we got to figure out how much mils that is. And so 70 micrograms divided by 16 micrograms, which is again our concentration per mil, which is going to give us 4.375 mils. And that is how many mils it takes in order to give us 70 micrograms. So we take that mils, and we know that this is how many mils we need per minute. So we need to find it out per hour. So we're going to take that, times it by 60 minutes, okay, to give us how many mils we need per hour. So in order to give 70 micrograms of epinephrine, we need to run this at 220 or 262.5 mils per hour. And if we run it at 262.5 mils per hour in our concentration that we have right now, it'll give us 70 micrograms of epinephrine every single minute. Okay, so that's how we figure it out. That's how we figured out our min dose and our max dose. You can do this with any dose that you need in between as well. You simply, again, figure out how many mils it is for that dose, and then you times that mils by 60 to give you a flow rate per hour. So you can type that into your pump or your dial flow, whatever you're using. You need to be precise with it is kind of my point, and that's why we have to do a little bit of math to figure out exactly how much we're going to give. So we've gone through the big parts of knowing that this is a myocardial infarction, so we're still going to treat this with ASA. We're still going to give fluids as long as there's no pulmonary compromise. Again, in 250 ml boluses, and then reassessing every time that we give 250 mils. That's the first basic things that we need to do. Next, again, remember, this is a myocardial infarction, so make sure you're treating it as such, giving them oxygen, giving them aspirin. Considering nitro once you've corrected the hypotension problem is a possibility as well. However, we have a lot on the go right now and a lot of contraindications and concerns with that. So nitro may not be something you're going to use in this particular patient, but pain control like fentanyl may be. So now that we've covered that out of the way, we have a bradycardic decompensated shock patient. So what do we need to do for those patients? Well, we need to make sure that we are prioritizing pacing, prioritizing increasing preload by using epinephrine if it's needed, and making sure that we're reassessing the patient to confirm that we are improving perfusion, improving that blood pressure with the combination of things that we're doing. And if needed, and if they are compensating, then we can start to consider using atropine as opposed to going pacing. But in this particular patient, we need to go down the other route. So that's what we have for you today. If you have any questions at all, please feel free to put them in the comments. I'll get to them. And again, this is going to be an interactive case on our website. So if you're interested in making continuing education credits by taking our cases, we do this on our website. So if you're interested in getting continuing education hours, we are CAPC accredited as well. You can absolutely do that. Shoot us a jump on our website, courses.mastermedics.com, and you can figure out all the options for continuing education there. Bye for now, and we'll see you next time.